Good morning, everyone, and a very warm welcome to this insightful session on musculoskeletal rehabilitation in hemophilia. I am Dr. Karan Jain, clinical occupational therapist at Seth GSMC and KEM Hospital, Mumbai, and your moderator for today. This session holds even more significance as we come together just ahead of World Hemophilia Day, which is on 17th April every year. It is a global initiative to raise awareness and understanding of hemophilia and other inherited bleeding disorders. Before we begin, it is my honor to welcome our distinguished guest with us today, Dr. Karuna Nadkarni, Head of Department and Associate Professor, Occupational Therapy, SAID GSMC and KEM Hospital, Mumbai. Dr. Karuna Nadkarni ma'am has been a pillar of strength and guidance in advancing the field of rehabilitation sciences, and her constant encouragement has helped shape the efforts in hemophilia care and training across many platforms. Ma'am, we are truly grateful for your presence, and may I invite you to kindly inaugurate the session and share a few words with us.
Good morning, one and all, and I welcome you all for today's webinar on musculoskeletal rehabilitation in hemophilia. Now, this workshop is very special to us because we are celebrating centenary year of St. GS Medical College and KM Hospital, and Diamond Jubilee, that is 75 years of existence of occupational therapy in St. GS Medical College and KM. So we have dual reasons for celebrating this whole workshop. And I'm very grateful to our experts, that is Dr. Kirti Kene and Dr. Saurabh Phadke, because they are part of the comprehensive team of the hemophilia management. Today you will get to learn about the nitty-gritties of managing hemophilia and also how you can engage these patients into meaningful occupations. And I'm sure you all will be very grateful to the knowledge that is shared by these presenters today. I'm very delighted to know that more than 400 people have have registered for today's webinar. And I'm very sure that it is going to be a huge success. I wish all of them a very good luck for this webinar. And I declare that the webinar is open for today. Thank you so much.
Thank you, ma'am. So moving along with the objectives of the webinar. To understand the basics of hemophilia from a rehabilitation perspective, to introduce screening tools and outcomes measured in musculoskeletal care, to explore theoretical models and frameworks in hemophilia rehabilitation, to share effective therapeutic strategies for enhancing MSK strength, to provide an open platform for interaction through a dedicated Q&A question at the end. Please use the chat box to submit your questions throughout the session, and I request no one should unmute their mic. So moving on with the webinar, I would like to introduce Dr. Kirti Patil ma'am, MOTH and BOTH from KEM Hospital, MOTH in Neurosciences, Senior Occupational Therapist, working with Comprehensive Care, Hemophilia Care Center since 2008, faculty at International Hemophilia Training Center, Mumbai, experienced in conducting national and international training programs, camps, and research in hemophilia care. I will now like to hand over the mic to Dr. Kirti ma'am.
So good morning, one and all. We have divided this session in 4 parts. So we will start with the first part, that is the basics of hemophilia. To understand, there are many types of bleeding disorder, but we will stick to the musculoskeletal rehabilitation, and the commonest bleeding disorder which encountered us at the IHTC centers are the hemophilia A and hemophilia B. Talking about hemophilia A, also called as factor VIII deficiency, it is a classic hemophilia and referred to as classic hemophilia because it has a prevalence of 80%, that is 1 in 10,000, 5,000 individual. It is an X-linked heritable coagulopathy, and mostly seen in 70% of the family history. We get a history of hemophilia A. The hallmark sign of hemophilia A or any bleeding disorder is the prolonged bleeding. In hemophilia A, we have a 25% development of inhibitor or antibodies against the factors. Coming to hemophilia B, also known as factor IX deficiency or the Christmas disease, it accounts to almost 20 to 30% of the patient. And unlike hemophilia A, it is also an X-linked coagulopathy. It has a prevalence of 5%, and the development of inhibitors is less as compared to hemophilia B. Let's see the genetic inheritance in hemophilia. When I'm talking about the genetic inheritance, we are talking here about hemophilia A and hemophilia B. Most, like the 70% of the family has a history of genetic inheritance. So the scenario on the right hand side, that when a female or the mother is a carrier, and if she marries to a normal person, then the X, because it's an X-linked recessive disease, there are 50% chances that at each birth a son will have an hemophilia, and 50% chances of each birth that a daughter will be a carrier. Now this boy or this hemophilic, when he grows up and marries to a normal person, that is a scenario on the left hand side. So when a hemophilic marries a non-carrier, none of the sons will be an hemophiliac, but all the daughters will be a carrier, because mother has been carried to the girl child. This scenario is mostly applicable in 70% of the family history. 30% of the family where there is a no family history, we can say there is a genetic mutation, and mutation can occur either in mother as a carrier or in the affected child. So how a hemophilia is diagnosed? So now a person comes to you, or the patient comes to you either with a family history or with no family history. So when there is a strong family history, so then it is easier to do a prenatal diagnosis. We do the CVS or the chronic villus sampling or the amniocentesis. If there is a remote history of a uncle or a carrier in the family, then the newborn can be screened for a specific factor deficiency in the family. But if there is no family history, how the patient is going to come to you for at the HTC center, he will have a history of bleeding, or bleeding when he will start his milestone, or he will have a continuous bleeding from his when he has a dental extractions or ecchymosis or subdural hematomas, and then the parents come to the emergency to get the evaluation done for the bleeding disorder. The basic primary investigations done are the screening coagulation test, that is the PT and APTT, which are decreased. And then when it is confirmed that there is a coagulation factor deficiency, then the specific definitive diagnosis for hemophilia to define the severity and the type of the disease is done, that is the factor assay. This it's very important for all the therapists involved with treating hemophilia to know the factor level, because if you see, the most of the times the patient who comes to you is going to be a hemophilia A or B who is having severe going to have a severe factor level. Severity is less than 1%. So how do we know there's factor levels? The severity of the hemophilia depends upon the amount of clotting factors that is missing. So when there is a factor which is circulating and it is less than 1%, then it is called as the hemophilia A severe. When it is between 1 to 5%, it is called moderate. And when it is more than 5%, it is classified as mild. So patient with severe hemophilia may bleed once or twice, and there are mostly spontaneous bleed. The patient will give you a history, will not always give you a history of a fall or an injury. He will come with a history of a spontaneous bleed or a breakthrough bleeds per week or once in 3 months. In contrast to those with the moderate or mild hemophilia, in whom the trauma or surgery is the cause of bleed. So this side of the right hand side of the table gives the bleeding episode. So when there is a hemophilia A and the severity is less than 1, there will be spontaneous bleed in the joint and muscles. And sometimes it happens that even when the factor corrections are given, even when the hemostasis is maintained, there will be a breakthrough bleeds. Compared to the mild and moderate, where there will be occasional or spontaneous occasional bleeding only on trauma or any surgeries. Coming to sites of bleeding, divided into two. What is relevant to us as a rehabilitation expert is the joint and the muscle bleeds. Most of the time, the joint and the muscle bleeds accommodate to almost 70 to 80%. Mucous membrane in the mouth, nose, and genitourinary tracts are also one of the bleeds which we come across. There are some life-threatening bleeds, that is the intracranial or the subdural hematoma, neck and throat bleed, and gastrointestinal bleed, which accounts to almost 20 to 30%. What are the common muscle and the joint bleeds which we come across? So there is something called target joints. If you see in this diagram, we can see that there are three major joint and three major muscles which bleed on and off. In the upper limb, you see there is an elbow joint. In lower limb, there are the weight-bearing joints like the knee joint and the ankle joint. Unlike in the muscle bleeds, we have a compartmental muscles like the forearm muscles, the calf muscles, and the iliopsoas muscles. So whenever a PWH, that is a person with hemophilia, is going to come to your clinic, he is going to have the following bleeds. The commonest will be the target joints, that is the knee, ankle, and the elbows. This is the approximate frequency. As I told earlier, the hemarthrosis or the joint in the bleeds in the joints contributes to the most, that is the 70 to 80%, and the muscle bleeds contribute to 10 to 20%. Other major bleeds may have 5 to 10%, and the central nervous system bleeds hardly any, less than 5%. Sometimes the central nervous system bleeds, that is the subdural hematoma, may or may not have the soft neurological signs. So now when there are common joint and muscle bleeds, what is going to be the position of comfort is always going to be in the flexion position. This table is very important. This we are going to talk more in the interventional part, because whenever there is a joint bleed and the patient keeps the joint in a flexion attitude, there is going to be an habitual. On that, we have to recognize and assess those postures and work on the intervention accordingly. If you see in the table, the knee, elbow, and ankle joint has a flexion attitude. The patient will have a triple deformity or will walk in the flexion attitude, or there will be extension loss, will be compensating with the spine, or that the hip will be flexed. So we need to work on this specific position, habitual posture, and plan our intervention accordingly. Coming to the muscle bleeds, similar like the knee joint bleeds, in the muscle bleeds, we have a posture of comfort, which is again in the flexion, most of the time in a flexion attitude. So we have most of the time whenever there is a muscle bleed in a patient, there will be a flexion attitude, and the patient will develop contracture and deformity will be followed. Now, coming to now, you know which are the commonest joint and the muscles which are going to bleed. Now we will quickly go through how to recognize a bleed. We can classify the bleeds into acute, subacute, chronic, and end-stage arthropathy. So whenever an acute bleed comes to your center, there will be a burning sensation in the joint, flame tensed, warm, and skin becomes bright and red. And the affected joint is mostly in the antalgic flexion and position and painful, and there will be decreased range of motions. Coming to the subacute phases, when the acute bleed is managed by CFCs or the coagulation factor concentrates, still there are many breakthrough bleeds because the patient rests for a while, and then immediately when he goes back to the work and the bleed is not completely subsided, there are subacute bleeds which comes along, and mostly it can cause a rebleed in the same joint, but the pain is tolerable and commonly associated with hypertrophic synovium. Most of the time there is a slightly lack of mobility in the joint. In the chronic presentation, you will see a lot of contractures, deformities going into arthropathy and chronic synovitis. We are going to talk about the pathophysiology in the coming slides. So you will have a better picture of how to distinguish between an acute, subacute, and a chronic bleed. And this is the end stage hemophilic arthropathy. So when there are repetitive hemarthrosis and the joint progressively go into a hemarthropathy, you will see a knobby joint appearance. There will be osteophytic bone overgrowth, FFDs, flexed flexion deformities. There will be fibrous ankylosis. There will be a lot of different kind of deformities, and mainly the commonest type is the triple deformity, in where we have flexion, valgus, posterior subluxation. Most of the time, the joints will be lax and malaligned. Okay, so this will explain the difference between difference and the cause for an end stage arthropathy. So now we will divide the development of hemophilic arthropathic stage into acute hemarthrosis, that is the acute bleed, chronic synovitis, and degenerative arthritis. So every joint has a synovial lining and has a limited capacity of absorbing blood flow. So when there is an incidence of hemarthrosis and there is a recurrent bleed in the same joint, what happens? It results in a level of blood breakdown products that the synovial membrane cannot remove, specifically the iron. So iron is the key constituent of hemoglobin found in erythrocytes, and throughout plays a major role in inflammation of the synovium. So this iron-rich breakdown product, hemosiderin, is thought to promote the production of pro-inflammatory cytokines such as interleukin-1, interleukin-6, and tumor necrosis factor. And in the induction of these genes, it causes cellular proliferation. So this leads to a synovial tissues. This causes the synovial hypertrophy, which leads to hemophilic synovitis. The synovium becomes increasingly vascular and hypertrophic, and then there is a chain reaction of inflammation, bleeding, and inflammation. Okay. So there is a vicious cycle. There is damage to the articular cartilage that makes the inflammation and synovial hypertrophy and results into a degenerative arthritis. So this process continues till there is a complete destruction or end stage arthropathy. So this cycle is very important to study, because as a therapist, if you start the early intervention or preventive management in the first stage, that is the acute hemarthrosis stages, the preceding end stage arthropathy can be avoided. These are now symptoms between hemarthrosis and hemophilic arthritis. So now we know that there are signs and symptoms which are associated with hemarthrosis. That is redness, muscle spasm, tingling sensation, inability to load the joint, and prodromal sensation of fullness. So specifically, this symptoms in the literature are called as the aura. But if these symptoms are untreated, then it goes into then there is an increase in the pain, swelling, warmth, and the limitation of motion and tense feeling, and then patient will not be able to load the joint, and there will be muscle spasm, and the joint will go into a fixed flexion deformity. Many of these signs and symptoms are also associated with a hemophilic arthropathy. So you can see on the right hand side. So what is the difference is in the advanced hemophilic arthropathy is characterized by a fibrinolytic capsule which limits the swelling. So a hemarthrosis can therefore be present in an arthropathic joint without any swelling on clinical presentation. So you have an arthropathic joint and you have an acute bleed, but it may happen that in the clinical presentation, a swelling or pain may or may not be present. And in the acute phase, existing flexion contracture makes the limitation in the range of motion difficult to access. So because there are already deformity has happened and now there is again a new hemarthrosis. So, and the patient is coming you for the first time. So you really don't know what was the ranges of the joint. So already a hemophilic arthropathy has set in. Very important term to know in hemophilia is the target joint. It is well defined as a joint in which 3 or more spontaneous bleed have occurred within a consecutive 6-month period. So the table gives you the typical changes which happens in knee, elbow, ankle, which are the target joints, which we will be talking about more in our intervention and rehabilitation part. So typical changes, what happens are radiological changes, which are shown in that. We have a flexion deformity, we have a triple deformity, rotational angles are changed, there are subluxations which are happening. So now coming to the medical management, or either how they are medically managed or prevented. So in a developed country where the factor are easily available, prophylaxis is the line of treatment. Okay, but in countries where there are limited resources, we have episodic or on-demand management. So whenever the patient comes to your center with a bleed, acute bleed, then episodic treatment is given. That is, the factor correction is given to them. Unlike prophylaxis in hemophilia, consists of a regular administration of therapeutic products aimed at maintaining the hemostasis to prevent bleeding, especially in the joint and the muscles, so that there is no future arthropathy or disability. Prophylaxis is always the first choice or recommended choice for the management of hemophilia. But if it is unavailable, then we can go for short-term prophylaxis. So just to know, primary prophylaxis is a prophylaxis which is given before any joint bleed has initiated. Secondary prophylaxis after the second joint bleed has initiated, and tertiary prophylaxis is after the onset of joint disease. Why it is important for a therapist to know about the prophylaxis protocol? Because whenever a patient comes to you with to your center where there are limited resources, and you are up to decide whether he will go for an elective surgery or any intra-articular procedure, then first, if you are planning to do with the conservative management, you can start with the secondary prophylaxis. Sometimes there are FFDs or there are contractures which are correctable. Then we can ask for a tertiary prophylaxis and try with the splintage, which we will talking more in details in our interventional part. There is something called periodic prophylaxis, like a periodic prophylaxis is a treatment given to prevent a bleed for a period not exceeding more than 45 weeks in a year. So intermediate prophylaxis is given to, mostly in our center, it is given to kids, school-going kids, so that when they are into a phase where there is a likelihood of having a joint bleeds more often. So intermediate periodic prophylaxis is the preferred line of treatment. Secondly, coming to the important parts, that is the inhibitors. So now you know the medical management is giving on-demand factors, or if you have, if the center has a prophylaxis management, then you can go for it. Sometimes it happens that recurrent use of factors leads to inhibitors. Why inhibitors? Because the IgG allow antibodies to the exogenous clotting factor 8 or factor 9 that neutralize the function of the clotting factors. It will not respond to the clotting factor. Mostly when it is suspected to do an inhibitor test, and any patient with hemophilia who fails to respond clinically to the clotting factor concentrate replacement therapy. Mostly it is encountered in severe hemophilia, and we have observed it more in hemophilia A than in hemophilia B. Treatment for the same is the conventional hemostatic bypassing agent, which is the FIBA, which is available, and the non-factor replacement therapy, it is the emicizumab. So these are the activities that are likely to cause the bleed. So we have different age groups who are coming to our center. The infant will come to our center with a circumcision, maybe history of circumcision, then handling, maybe achieving milestone, is learning to walk, and the parents observe some kind of hematomas, and then they come to our center. So these are the mostly the likely activities which cause a bleed in the infant. Going to the toddler phase, learning to walk, falls is the most activities which will cause a bleeding then. When the child starts going to the school, so now there is a new environment, there will be a lot of running, climbing, sports activities will be introduced. And this is the environment in which he may have a lot of bleeds, and he will come with the bleeds maybe once or twice or maybe more than that in a month. Coming to the adolescence. So now till these 3 phases, the child was completely protected, maybe overprotected by the parents. And now he is into adolescence where there are new activities which he wants to explore, or maybe wants to hide, kind of bleeds from his friends. So this is the time, or maybe overexerting a joint, overacting a muscles, using computers for the longer duration. These are all some of the activities which may induce a bleed. So to sum up, what will be the musculoskeletal complications? So, yes, of course, target joints. When there are recurrent bleeds in a specific joint, we have a lot of target joints. We have target joints leading to synovitis. So in hemophilia care, chronic synovitis is generally used for a synovitis which is existing more than 3 months or longer. Then we label it as a chronic synovitis. There are a lot of muscle hemorrhages, compartment syndrome. Whenever there are muscle hemorrhages, it may or may not be involved with a nerve involvement. There will be compartment syndrome, contracture deformity, and in the end, of course, the end-stage hemophilic arthropathy, as we have discussed. Along with that, there will be associated conditions like pseudotumors, fractures, and limb length discrepancy. The pseudotumors are and the potential in the limb are life-threatening condition, and which is very much unique to hemophilia. Commonly seen in long bones and the pelvis. It occurs as a result of inadequate treatment of the soft tissue bleeds, usually in the muscles adjacent to the bones, which can be secondarily involved. And if not treated, pseudotumor can reach a very enormous size, causing pressure on the neurovascular structures, and may lead to pathological fractures also sometimes. Fractures are not very uncommon with hemophilia, but due to the low level of weight bearing, ambulation, very inactivity, mostly in knee and hip joint. Fracturing around joints have significant loss of range of motion, and in bones which are osteoporotic. This is a very important slide because it talks about the comprehensive care of hemophilia. So now this is the multidisciplinary team which we have at our center, where the center is the patient, and we all, the therapists, the dietitian, the hematologists, surgeons, nurse, work together in a multidisciplinary form for the better outcomes and measures, and for the good quality of life of a hemophilic patient.
Thank you, ma'am. It really helped us in knowing the overview on hemophilia and how it affects our musculoskeletal health. It was an eye-opener for us that how hemophilia affects our MSK health. It helped us how we can have an early identification of hemophilia and about the treatment of hemophilia and other various conditions that occur in hemophilia, like pseudotumor and various others. Thank you. So moving on to our second session, screening of MSK health and outcome measures. So I would like to introduce Dr. Saurabh Phadke sir, BOTH and MOTH from KEM, MOTH in Musculoskeletal Sciences, Assistant Professor at GSMC and KEM Hospital, Mumbai, Co-Director of Synerg Ace Rehab Solutions, over a decade of experience in hemophilia care, and certified in HGHS, kinesiotaping, manual therapy, and sports rehab. I would like to hand over the mic to Dr. Saurabh Phadke sir.
Thank you, Karan. We'll be seeing the OT assessment in hemophilia. So in hemophilia, when we see, we generally do a holistic OT assessment. So here we see the occupations, context, performance patterns, performance skills, and client factors, which are generally going into dysfunction. So the patient having problems in occupations in ADL, IADL, health management, rest, sleep, as the sleep patterns are disturbed, education, work, play, and leisure. If their context, like environmental factors, are having any problems because of that, then personal factors. How are the habits? How are the routines? Their roles? Are they affecting the performance patterns in their daily life in hemophilia because of the? How are the motor skills, process skills, and social interactions, and their client factors such as value, belief, and body functions and body structures. After that, we do a detailed physical assessment. So in this, we will see for the acute musculoskeletal bleed. So details of the bleed, onset and progression of symptoms. Then how was the mechanism of injury? If any first aid or price was used, and what was the response to the treatment? Then what type of the pain is there? What is the location of pain? How is the intensity and any aggravating factors? And if there is any pain with the movement. Then bleed history, any recent joint or muscle bleeds since the last visit. What was the reason for those bleeds? Previous target joints and location and their numbers. Usual activities over there with what the patient does, and are they interfering with their daily life? Then identification of the bleeding patterns. What factors or plasma products they have taken. Usual response to the treatment for the bleeds, and chronic arthropathy, if any, what is the location of that? Then subjective interview history, other medical and surgical history, pain history and treatment, patient concerns and their complaints, social history like family, work, culture, language, what they speak, ADL concerns, if they are having any. Then participation in activities of daily living, exercises, sports, PT class, recreation, leisure pursuits. Currently, are they using any kind of walking aid? Any kind of orthopedic issues because of the long-standing hemophilia problems, and their educational needs, as in how literate are they about their health, and absence due to the physical needs. Then coming to the objective information, wherein we observe and inspect the all the joints. So palpation and inspection of the joints at the rest and during active range of motion. Note the abnormalities like synovitis, crepitus, swelling, temperature, redness, spasm, and atrophy. Then range of motion to be checked in passive, and if there are any atypical end feel or say pathological end feel like bony or boggy end feel. Then muscle length and flexibility, especially for the two joint muscles. And if there is a hypermobility, like you can see in the picture, we can see genu recurvatum. Then strength, active movements, compare it with the contralateral limb, or in case with the chronic arthropathy, baseline measurements, pain with the movement, muscle testing or functional strength for above mentioned range of motion measurements, posture and alignment, preferably to be taken in the standing position. Also check for limb length discrepancy, balance, sensation, because many times in femoral nerve compression, there is a sensory loss. Then proprioception, observational gait analysis, and their functional activities. Activities and participation throughout the lifespan. We can check the gross motor development in school, how they are doing in school, work, how they are able to do physical activities, sports, leisure, social, cultural activities, and their self-care. And any kind of special test done for bleeding disorder specifically, for orthopedic concerns, for developmental concerns, fall assessment, and neuromotor assessments. Gait. So early gait compensation are often seen in a young children. You can see that. Parents, even with an untrained eye, doesn't look right. Observe any deviation while walking. Key points to observe: pelvic alignment, hip and knee movements, foot and symmetrical patterns should be present. Posture. People with hemophilia may develop postural issues due to repeated joint bleeds, that is hemarthrosis, leading to pain, restricted movement, and muscle atrophy, potentially resulting in impaired balance and distinctive posture. So changes generally occur like, flexion deformities, repeated bleeds in the joints can lead to flexion deformities of elbow, knees, and hips. Lumbar lordosis and exaggerated arch in the back can occur. Plantarflex ankles, pelvic asymmetry, increased body sway, and reduced postural control. This is an example of the joint bleed where the therapist will check for the position of comfort, habitual posture, and leading potential problems. For example, if there is a bleed in the knee, the position of comfort will be flexion. So habitual posture often will be seen as a walking on a hip knee flexion and ankle in plantar flexion. And the potential problems will be pain in the knee, stress on ankle, overuse of hamstrings, and weak quadriceps. So likewise in elbow and ankle can also be evaluated. This is for the muscle bleed. So if there is a bleed in the hamstrings, position of comfort will be knee flexion and hip extension. Habitual posture will be attained will be knee flexion, and potential problems like altered gait, knee flexed, and walking on toes. Similarly, for bicep brachii, gastrocnemius, iliopsoas, and quadriceps. Muscle balance in hemophilia. So this is muscles have three important functions. They have a role in a static control of posture and alignment of joints, a role in a dynamic control and production of movement, and they also provide important proprioceptive input into the CNS. The concept of muscle balance is that muscles provide stability and movement, but it is a balance between the different muscle groups that ensures that correct joint loading and correct alignment occurs. Incorrect loading of tissues and misalignment may lead to development of tissue pathology. Muscle respond to dysfunction in one of the two ways, either by becoming overactive and tight or by becoming inhibited and weak. This does not occur in a random fashion, but frequently follows a common patterns. So when we classify the muscles with mainly stabilizing characteristics can be subclassified into two groups, local stabilizers and global stabilizers. Muscles with mainly mobilizing characteristics may be termed as global mobilizers. So for muscle balance to occur, muscles with primary stabilizing characteristics should demonstrate greater tonic recruitment. Muscles with mainly mobilizing characteristics should demonstrate greater phasic recruitment, that is, ability to generate relatively high forces briefly. Then what are the local stabilizing muscles? So examples are like, of this are deep neck flexors, multifidus, transverse abdominis, which are all concerned with the stability of the trunk. The main roles of these deep local muscles are joint protection and support and control of ideal alignment of the spine. They provide an important proprioceptive function about where the trunk and the body are in space. If there is a pain for whatever reason, these muscles will become inhibited. There will be a selective weakness, a decrease in force production, and decrease in tonic holding capacity or endurance capacity of the muscle. It is possible that lordotic posture resulting from a iliopsoas bleed may lead to transverse abdominis inhibition, as this posture is associated with tight hip flexors and weak abdominals. If left untreated, this could lead to insufficient stability within the trunk and subsequently other symptoms such as low back pain. The clinical implication is that patient with hemophilia and musculoskeletal pathology affecting the spine or peripheral joints may have poor trunk control. Therefore, assessment of stability in the trunk is important, and where necessary, treatment must be considered. And coming to the global stabilizing muscles, the global stabilizers such as lower and middle trapezius and gluteal muscles are not only stabilizers, but they also produce torque. They tend to produce movement in one plane only and have an important role in controlling anti-gravity positions and are primarily involved in slow, controlled, eccentric movements and deceleration of joint movements. Dysfunctions in these muscles due to pain leads to inhibition of the muscle with delayed activation. These muscles are lengthened and test weak in inner range positions. The activation threshold of these muscles increases, so it becomes more difficult to recruit tonic fibers. However, more phasic fibers which fatigue quickly are recruited. And the global mobilizing muscles like gastrocnemius and hamstrings, these muscles mainly are the torque producers. They tend to be located more superficially than local stabilizers and are not linked directly to the joints. They are usually fusiform long fibers that are required for increased load and speed. And when greater muscular forces are needed, they are having a tertiary stabilizing role. So there's a need for standardized outcome measure. So why do we need outcome measure for joint health? So this is for to determine if our intervention is working correctly, to determine if we are preventing the joint disease. Criteria on which our decision making depends is the target joint developing, is the clotting factor adequate, is the current rehab treatment no longer working, is the surgical intervention required, and long-term monitoring for rehab, post-surgery and post-medical intervention. Then coming to the standardized measure like Hemophilia Joint Healthcare HJHS score, it is developed by International Prophylaxis Study Group. It is an impairment measure developed to identify key markers of joint structure and function in persons with hemophilia. It has a 6 index joints like bilateral elbows, bilateral knees and ankles, and 8-item scale plus the global gait quantifies the joint status. It provides a systematic, reliable and valid way of assessing joint health, tracking it over time. It allows comparisons across population globally and in a multicentric studies. So this is an overview of a HJHS version 2.1. The items are there: swelling, duration of swelling, atrophy, crepitus, flexion loss, extension loss, and so on. And the scoring is given. So the total scores are 124. Axial alignment not to be monitored and not to be scored. So the greater the score, bad is the joint health. What can the HJHS do? It is a reliable and a valid tool for assessing joint health. It provides a systematic and organized valid way to assess and monitor elbows, knees and ankles. It is a useful tool for training therapists new to the treating hemophilia. It allows to quantify and score joint status, comparing it over time and across populations. In thoroughly evaluating each item, like swelling, muscle atrophy, etc., the HJHS provides a picture and a score of primarily structural joint status. It is a very sensitive scale, so even a difference of 4 points can make us understand how is the joint held. What HJHS cannot do. So it does not assess all the adjacent joints, specifically shoulder and the wrist in upper extremity and hip in lower extremity. It cannot assess whether one joint interferes with the other joint's function. It cannot be done after acute bleed. It requires at least 2 weeks or longer till there is a no bleeding. It does not assess whether muscle imbalance, weakness or tightness is interfering with the mobility. It does not assess quality of life, activity or participation, or how the person functions in the community. Coming to the ADL part, here we use the FISH scale, that is the Functional Independence Score in Hemophilia. It has 8 items which like eating, grooming, bathing, dressing, chair transfer, squatting, walking, stair climbing and running. Each activity is graded according to the amount of assistance required to perform it. The FISH was originally designed to compare the patient's basic functionality with that of the normal healthy individuals. The current version therefore has a ceiling effect when applied to those with the minimal musculoskeletal changes. It is not designed to assess challenging activities in individuals with relatively normal function ability. For ADL, it requires around 15 to 20 minutes to administer. Each activity should be scored only after observing the subject performing the task and not based on the subjective ability or not even on the history. For some tasks, the required action may be simulated in the clinic and not actually performed. So each activity is graded from 1 to 4 according to the amount of assistance required to perform the activity. 1 is maximum assistance and 4 is independent. So total maximum score is 32. Higher score is a better outcome. Summarizing the assessment part, longitudinal assessment and outcome measures are required, periodical and quarterly assessments, understanding baseline parameters for planning intervention, reassess the effectiveness of intervention and helping to provide a multidisciplinary approach of care. Thank you.
Thank you, sir. HGHS was a great insight for us, and it will help us in further evaluation and assessment of our hemophilic patients. Now we will move on to theories and models used in hemophilia care. I will like to hand over the mic to Dr. Kirti.
We'll quickly go through the theories and models which are used in hemophilia care. So, frame of reference or the models are the intervening mechanisms used by occupational therapists between the theories and the practice. So establishing a link between the theory and practice is a part of clinical reasoning process. It begins with the selection of specific frame of reference which can be used for PWH. The transition from the theory to a viable treatment strategy is not direct, and an intermediate mechanism is required. So we use lots of theories and models in to use this mechanisms. Theories forms are derived from scientific basis for OT practice and are delivered for a number of derived from a number of disciplines, which can be biological science, psychology, sociology, medicine, and occupational science. Function of a theory is to explain, describe, and preferably derive the behavior and understand the behavior and to make any changes for the function dysfunction. And for this purpose, theories must be transferred to the interventional part. Theoretical knowledge must be systematically reorganized to provide guide on how to produce desired change in behavior and to contribute to an understanding of function, dysfunction, evaluation, and treatment. So the first frame of reference which we will be using for hemophilia would be the biomechanical frame of reference, which focuses on assessing and improving the muscle-related issues, that is the range of muscle strength, gait, deformities, etc. So, and it is a remedial approach that aims to restore and adapt movement for the functional activity. So now that you have learned from the assessment part that there will be a lot of range restriction, there will be swelling, there will be hematomas on and off. So we use the biomechanical frame of reference, which will be designed around the purposeful activities and which can be used to improve that range, strength, and endurance. And the goal of this frame is to prevent further deterioration, maintain the existing ranges, and restore the range, and if any compensatory movement or adaptation if required. Coming to the second frame of reference, that is the rehabilitative frame of reference, which focuses on maximizing the functional abilities and quality of life, despite the limitation imposed by hemophilia. So now that you know there is a child with hemophilia, with flexion deformity, and he wants to go to the school, or is an adult who wants to go back to his work. So rehabilitative frame of reference can emphasize on adapting and compensating for the impairment through various strategies, including, of course, exercise, psychosocial support, education, environmental modification, and assistive technology, which will be discussing in brief. Which will be discussing more in the upcoming rehabilitative slides. Very important model, that is the person-environment model. So it is used to assess an individual occupational performance, identify the areas of difficulties, potential barriers, and support within the person, environment, and occupation. So this model, when we use, helps in the achieving the independence in the environment and achieve the occupational performance. So when applied to a person with hemophilia, it's understood how their personal characters, like the personal factors, like the mobility, social skill, psychosocial skill, or the self components or the values which the individual pursues as the personal values or the roles to the specific occupation as in whether he is into what stage of development. We need to assess the environment in which they live. The environment could be physical environment, social environment, or the institutional environment. When I say institutional environment, if a child wants to reach to a school or or a hemophilic wants to commute through the public transport and go to a office or access the healthcare or employment opportunities. In the social environment, a family support, social networks is required. Social network is mainly supported by the hemophilia societies, hemophilia federations, the societies which are spread all across the country, which are run by the hemophilics, and they provide a very good environment to the person so that they attend their occupations. Physical environments like the homework and supportive equipments, like if a patient is using a crutch or a walking aids, so that physical environment has to be assessed and accordingly intervention has to be made. So this all environment, when we are assessing into the occupation, the overall performance and the well-being is managed in the perspective of activities of daily living, workplace and academic job performance, and few of his leisure activities. Social participation model. This model emphasizes the importance of social participation for overall well-being and recognize that restriction in social activities can be a significant impact on the mental and the quality of life. So again, hemophilia societies, they have subgroups like women's group, youth groups. A lot of humanitarian aids is provided by the World Federation of Hemophilia, so that all the PWH are on the same page. They have a lot of social participation. They come out of the dysfunction and goes into a good occupational based purposeful activities and have a good quality of life. Occupational adaptations. This valuable framework for occupational therapists helps the person with hemophilia overcome challenges and achieves their occupational goals by focusing on interaction between the person, environment, and the demands, just like the PEO model, and facilitate their ability to adapt to these demands. So there are a lot of adaptations, like if a person with the hemophilia is not opting for any surgical intervention and he still has some deformities and he wants to do the adaptation. So any adaptations or environmental adaptations, if any required, or any at the workplace or at the school or at the homes, if required, can be done within this frame. Very important is the model of human occupation. This helps in understanding and addressing the occupational challenges faced by a person with hemophilia. It helps explain how motivation, habits, and performance capacity influence the participation in the meaningful activities. It is considered that the habituation, that is the roles and the routines, what the person has already achieved to perform his performance skills in the given environment, can help him to achieve the occupational and purposeful activities. So MOHO is considered an impact of the environment on basically the occupational behavior and helps in designing intervention that promote their engagement in meaningful activities. The biopsychosocial model, despite the recent advances or the great strides in the hemophilia care in the recent year, hemophilics continue to face a psychosocial challenge within the hemophilia-related musculoskeletal complications. So it recognizes that the hemophilia's chronic nature and its impact on daily life can lead to a psychological challenges and thus affects the social interaction. Comprehensive assessment of hemophilia require not only at the physical but at the emotional and the social well-being level also, and a tailor-made intervention considering the physical needs as well as the psychological and social needs has to be addressed. Family support and a psychosocial support or self-help group or counseling will help. Again, here hemophilia societies, the youth group, the parental group helps a lot to overcome with this biopsychosocial models. Community-based rehabilitation model empower PWH, that is person with hemophilia, and their families within the communities where there are limited resources. country like us, where the factor availability is less, prophylaxis is not be accessible to all. So in this limited resources, community-based rehabilitation helps a lot, improving the lives of PWH with limited access to specialized care, which achieves the maximum independence and the quality of life. A lot of education and awareness camps are being done by the society at national and at the national level. A lot of social participation happens not only from the PWH at the local level, but at the national level too. Also, community-based rehab talks about return to work of an hemophilic, so that any adaptations, if required, can be done, and then he has a smooth functioning at his workplace. So in summary, regarding the frames of reference and the models, the frames of reference and the models are intervening mechanism used by occupational therapists to bridge the gap between the theories and practice. Theories form the scientific base for occupational therapy practice and are derived from a number of disciplines. As I said, biological science, medicine, psychology, sociology, and occupational science. Theoretical knowledge must be systematically reorganized to prevent guidance on how to produce the desired change in the behavior and contribute to the understanding of function, dysfunction, evaluation, and treatment. Therapists should aim to maximize the quality of life and movement potential within the sphere of promotion, prevention, treatment, adaptation, and rehabilitation. Social participation prescribing becomes much easier to link people with activities schemes and prospective hobbies in the community to help improve and sustain both physical and mental well-being.
Thank you, ma'am. It was very helpful. Now we know how we can use different models and their application in hemophilia, and how does a hemophilic patient get affected, his or her social or mental health gets affected. So now we will move on to therapeutic interventions and care in hemophilia. I would now like to hand over the mic to Dr. Saurabh sir. Thank you.
Okay, so we'll be starting with the rehabilitation in hemophilia. So rehabilitation in hemophilia, generally we have this 3 stages: acute, subacute, and chronic stage. But it really depends. Like for example, a patient can have all the 3 stages within him. For example, he will having elbow bleed in stage 1, whereas the knee bleed can be in a stage 3. So acute stage, in stage 1, there can be a muscular hematomas, acute hemarthrosis. Stage 2, acute synovitis and target joint developing. And in chronic stage 3, it can be chronic synovitis and hemarthropathy. So management is each step poses a unique challenges with respect to age groups, occupations, often requiring long-term individualized approach of care. Muscle hematoma. So muscle hemorrhages occur in 10 to 20% of patients, although the bleeding into the central nervous system is less than 5%. It is generally life-threatening. Bleeds into the muscle cause range of motion limitation, disability, and reduced quality of life of the hemophilia patient. Muscle hematomas develop when the muscle is overstretched or when there is a direct trauma to the muscle, which leads to the fibers to tear and bleed. The hematomas in the gluteal or thigh regions and calf can reach very large sizes. Depending on the location, some hematomas can be hazardous, like examples like bleeding into a gluteal muscle or popliteal fossa may compress the sciatic nerve. Bleeding into anterior compartment of the forearm may compress the median or ulnar nerve and may cause Volkmann's ischemic contracture. Bleeding into iliopsoas muscle may compress the femoral nerve. Iliopsoas hematoma is one of the most commonly seen muscular hematomas in hemophiliac patient. Since the hematoma grows gradually, it may cause a delayed diagnosis. As a result, the diagnosis is usually made when symptoms of femoral nerve compression or anemia is observed. Muscular bleeding in hemophilia carries the important risk of developing compartment syndrome, pseudotumors, which have led to series of serious debilitating consequences, including death. The first 48 hours after the muscular bleed is defined as an acute phase of muscle hematoma. The management of acute hematoma includes immediate replacement of clotting factors, rest, ice compression, except for iliopsoas muscle, and elevation. So coming to this price and police principles, what is that? So price is protection, rest, ice, compression, elevation, and rehabilitation. Is recommended a new acronym like police, which is replacing rest with optimal loading. This has been suggested to encourage therapists to consider the role, type, timing, and mechanism of rest and the loading of tissue. So optimal loading is an umbrella term for any exercise or therapy intervention and includes traditional interventions like crutches, braces, and supports, but also a wide range of manual techniques to restore histological and mechanical properties of the soft tissue. So the police management of hemarthrosis and supporting evidence is well described in the guidelines by Hanley et al. The rationale for protection and rest after acute hemarthrosis is to minimize the bleeding of the fragile synovial tissue. Regarding the load that can be applied, is indicated by forced loading of a joint, which with the intra-articular blood results in more cartilage matrix damage when compared with no forced loading. Thus, it may be beneficial to avoid intra-articular blood. However, prolonged rest can negatively affect joint function through reduction in muscle strength, affecting tissue biomechanics and dynamic joint control. The second stage of the subacute phase of the muscular hematoma can be from 3 days to 12 days. Rehabilitation during this stage includes pain-free stretching exercises, functional massage, and movement to prevent muscle fibrosis. At the third stage, depending on the patient's pain and performance, gradual muscle strengthening exercises can be added to the rehabilitation program. Hydrotherapy is a safe and effective method for both the second and third stage of muscular hematoma. Proprioceptive neuromuscular facilitation techniques can be applied in the gentle way depending on the patient's tolerance. So we'll be taking one example of the muscle hematoma, that is the iliopsoas bleed. There can be a pain in the lower abdomen, groin, or the lower back pain, pain on extension but not on the rotation of the hip joint. There can be a paresthesia in the middle aspect of the thigh or other signs of femoral nerve compression such as loss of patellar reflex and quadriceps weakness. The symptoms may mimic acute appendicitis, including a positive Bloomberg sign. This is a clinical sign in which there is a pain upon removal of pressure rather than application of pressure to the abdomen. So in this case, hospitalize the patient for observation and control the control of pain. It is useful to confirm the diagnosis and monitor recovery with the imaging study, ultrasonography, CT scan or MRI can be done. Maintain strict bed rest. Ambulation with crutches is not permitted as the ambulation requires contraction of the muscle. Limit the patient's activity until the pain resolves and the hip extension improves. A carefully supervised rehab is a key to restoring full activity and function and preventing rebleeding. So restoration of the complete hip extension before returning to full activity is recommended. If residual neuromuscular deficits persist, further orthotic support may be necessary. Coming to the hemarthrosis, that is the bleed in the joint. Hemarthrosis develops within the few hours, and the typical signs of the clinical examinations are like inflamed, warm joints, very limited range of motion, and antalgic flexion position of the affected joint. In children with severe hemophilia, the first spontaneous hemarthrosis typically occurs before 2 years of age, but may occur later also. If inadequately treated, repeated bleeding will lead to progressive hematoma, deterioration of the joint and muscle. This will lead to severe loss of function due to joint deformity, loss of motion, muscular atrophy, contractures within the first 2 decades of the life. The origin of the bleeding is the synovium, which is a very delicate and highly vascular tissue that lines or lubricates the joint space. Very early bleeding in the joints may recognize by the person experiencing it as a tingling sensation and tightness within the joint. This aura precedes the actual occurrence of the clinical features of acute hemarthrosis, pain, swelling, and a limitation of motion. Once the blood fills the joint cavity, the joint will appear swollen and feel warm and tender. This causes the joint to seek most comfortable position, which is a flexion. Any attempt to change this position may cause severe pain, limiting motion and secondary muscle spasm. Acute hemarthrosis does not result in secondary changes to the synovial cells. Once resolved, the patient generally remains free from new bleeding episodes for prolonged periods of time. So what are the goals of hemarthrosis? It is to stop the bleeding as soon as possible. Ideally, this should occur when the person recognizes the aura. As in acute hematomas, the price regimen or the police is the first option of treatment of acute hemarthrosis. Immobilization of the joint and avoidance of the weight bearing during the first week is necessary to prevent rebleeding and cartilage damage. In addition, it is important to provide a proper balance between rest, early immobilization, and weight bearing to prevent the negative effects of immobilization and minimizing the rebleeding. Bleeding in the lower extremity requires at least 1 day of bed rest and protected weight bearing on affected side during the following 5 to 7 days. The extremity should be elevated when sitting and crutches must be used when walking. And in upper extremity, bleeds no lifting and carrying objects for 5 to 7. So example of this hemarthrosis can be taken as a knee bleed. So in knee joint hemarthrosis, applying compressive bandages is valuable. If the joint bleeding is in upper extremity, similar lifting, carrying and heavy objects are contraindicated. So as soon as the pain and swelling begins to subside, the patient should attempt to change the position of the affected joint from position of comfort to the position of function. Gradual decreasing the flexion on the joint and striving for complete extension is required. Gentle passive stretching and, more importantly, active muscle contractions to gain extension. The sooner the joint is in position of function, the active muscle exercises and proprioceptive training must be instituted and continued until complete bleed joint range of motion and functioning are restored. And that is a sign of acute synovitis had dissipated. Hemarthrosis can cause severe disability and it reduces the quality of life of the hemophilic patient. Recurrent hemarthrosis results in chronic inflammation of the synovium. This inflammation is the main cause of the vicious cycle of hemarthrosis, synovitis, hemarthrosis, also called as bleed, synovitis, bleed cycle. So firstly, the synovium becomes unable to reabsorb the intra-articular blood and causes synovial hypertrophy. Then impingement of the hypervascularized tissues triggers the bleeding again. Therefore, the principal approach is to avoid acute joint bleeding. If there is a bleeding, it is paramount to manage it rapidly and efficiently as soon as possible. The recurrent intra-articular hemorrhage caused chondrocyte apoptosis, which eventually results in hemophilic arthropathy. Then prevention of the target joints. Bleeds can be treated early and completely by minimizing the risk of developing chronic synovitis. Identify the bleeds early. HHS will surely help as it is very sensitive scale. Identify the muscle imbalances and implement price police protocol as soon as possible as the bleed is identified. Restore motion, strength, proprioception to the pre-bleed level. Protect the joint as the bleed resolves. Educate patient and caregivers. Set routine for regular exercises. And early aggressive management will break the bleed synovitis bleed cycle. Preservation of joint and muscle mechanics. For this, HHS will help. Stretching exercises, active, passive, depends on inhibitor status of the patient. Muscle energy techniques like PIR and RI will help to increase the range of motion. Therapeutic exercises from acute to subacute, you can give active, assisted, and active, and then lastly resistive exercises. Use of splints, orthosis, protective cuff and headgears, use of walking aids as required, and footwear modification. Muscle imbalances and posture correction. So there are local stabilizing, as we have seen in assessment, there are local stabilizing muscles, there are global stabilizing muscles, and global mobilizing muscles. As the stabilizing and mobilizing muscles have different functional characteristics, they must be assessed and treated differently. The stabilizing muscles are assessed by their ability to activate and hold in the inner range, while the muscle length are more appropriate for determination dysfunction in mobilizing muscles. A progressive program of muscle rehabilitation has been described. This includes control of stability of the muscles in neutral position. In the initial stages of the program, focus on low load, low effort, and isolated activation of the muscles in pain-free position, which can be ideal for patients with marked joint pathology. When treating the local stabilizing muscles, it is important to focus on the appropriate activation of the affected muscles in isolation from the mobilizing muscles. Facilitation strategies can be used. It is important to activate these muscles in the absence of pain. Otherwise, these muscles will remain inhibited. Once activated, focus must remain on endurance capacity by increasing the holding time and avoiding the substitution of the other muscles. Once the correct activation patterns have been established, exercises should be repeated frequently so that it goes into a functional patterns. It may not be appropriate to progress to high load activities when rehabilitating the people with hemophilia. So fast ballistic exercises are not at all indicated because it can inhibit the stabilizing the muscles. The classic muscle test position of inner range holds are used for the global stabilizers, again progressing by increasing the holding time. When imbalances are present between the muscle groups, the stability muscles are activated prior to the lengthening the overactive short muscles. If the mobilizing muscles are just hypertonic, they will relax by the reciprocal inhibition as a muscle energy technique. If the mobilizing muscles are if they are adaptively shortened, then it is necessary to add lengthening techniques for the tight muscles. The trunk, cervical, spine, scapula, and pelvis should provide a stable base from which functional movement can occur. Clinically poor stability of the trunk is often associated with tightness of more peripheral muscles such as hamstrings or gastrocnemius as the body strives to achieve the stability. Coming to the synovitis part, so Palazzi et al. Has classified the clinical presentation of the affected joints in a very simple system. The end stage of the disease is manifested by a fibrous contracture, loss of joint space, and substantial disorganization of the joint structures, and a pain due to joint degeneration. The origin of hemophilic synovitis is clearly related to the chronic accumulation of the blood within the joint. Once joint develops recurrent bleeding episodes, that's called target joint, chronic changes will occur. This can affect synovium, cartilage, capsule, ligament, bone, and muscles. So when the bleeding occurs, the collected blood breakdown products must be removed from the joint by the synovial membrane. This membrane has the ability to absorb the breakdown products of blood after an acute isolated hematemesis. However, when the bleeding occurs repeatedly into the same joint over a period of few weeks, the amount of blood breakdown products overwhelms the synovial membrane's ability to absorb them and transfer to the central circulatory system. As a result, synovial membrane becomes chronically inflamed with a subsequent increase in volume. That is called synovial hypertrophy. So when it goes into a long-term occurrence, that is called degeneration of joint, diagnosis can be done by physical examination and ultrasound and MRI. This joint, the synovitis joint, feels spongy to touch. It has a very muscle weakness. Muscle atrophy can be seen. Contractures can develop, deformity, joint instability, overgrowth of epiphyseal plate, limb length discrepancy, and lastly, hemophilic arthropathy will occur. Management. For the synovitis management, factor replacement will be given. If the patient is on prophylaxis, that is 6 to 8 weeks, it will be better for the rehab. So intra-articular long-acting steroids in advanced stage of synovitis, like atrium trials, can be done. Price protocols, exercises, splinting, functional training, and lastly, synovectomy, that is open or radioactive synovectomy, can be done. So these are the guidelines to choose intervention in synovitis. So for non-surgical, 2 weeks of prophylaxis will be required post radioactive synovectomy. For non-surgical purpose, the flexion contracture should be up to 60 degrees, absence of secondary joint involvement, and the end field should be reasonable. And if we see the improvement, at least 5 degree per week improvement should be noted. And for the surgical management, flexure contraction more than 60 degrees, and after the failure of conservative methods and management, which is done for at least for 6 to 8 weeks. In surgical, they will do a soft tissue release with a serial casting or else open synovectomy. In non-surgical, rehab is done under prophylaxis for 6 weeks, and otherwise intra-articular synovectomies like chemical and radioactive is done. Fractures are relatively less frequent in this disease due to patients' protected lifestyle and lower level of activities. However, a person with hemophilic arthropathy should still be considered the risk of fractures around the joints that have a significant loss of motion and bones have gone osteoporotic. So immediate factor concentrate the replacement. The actual management of fracture should be performed in a manner appropriate for the specific fracture. Then this includes operative treatment if needed under coverage of a clotting factor. Care should be taken to avoid prolonged immobilization that could lead to a significant limitation of range of motion in the adjacent joints. Circumferential plasters should be avoided. Splints will be most preferred. Fractures adjacent to the joints with existing hemophilic joint degeneration deserve special attention. Prolonged immobilization is prone to lead significant limitation of range of motion. Rehab should be started as soon as possible. The fracture is stabilized to restore motion, muscle strength, and function. Regular exercise, fall prevention strategies, and optimization of calcium vitamin D intake are all recommended for further fracture prevention. Pseudotumors. Starker in 1918 described this potentially limb-threatening and life-threatening condition unique to hemophilia. It is the most commonly seen in the long bones or the pelvis. It occurs as a result of inadequately treated and incompletely reabsorbed soft tissue clots, usually in the muscle or adjacent to the periosteum where the bleeding is encapsulated and erodes the bone. So pseudotumors produces recognizable vascularization, and if not treated can reach an enormous size, causing pressure on the neurovascular structures and pathological fractures that mimics a malignant tumors. So generally they are observed in patients who live far from the treatment centers or who have no follow-up of their treatment. So they present late for the adequate treatment. Diagnosis is made by physical findings of a localized mass. Femoral location is the most frequent. Radiographs are usually enough. Otherwise, MRI and CT can be done. Management depends on the site, size, rate of growth, effect of adjoining structures. Options recommended by WFH guidelines include initial conservative approach with at least 6 weeks of factor administration with the follow-up MRI. Surgical excisions including limb amputations may be necessary. For the large pseudotumors, particularly if they erode the long bones, surgery must be performed by the teams with appropriate experience in hemophilia management. After excision, regular rehabilitation can be started. Coming to the hemophilic arthropathy, which is the stage 3. In the hemophilic patients experiences multiple hemarthrosis episodes in a target joint and develops severe joint destruction as early in their second or third decades of life. So joint preservation is no longer possible, and remaining available treatment is a total joint arthroplasty, especially for the major joints of the lower extremity. So end-stage hemophilic arthropathy in hip and knee can be successfully treated with the TKR, THR. Hemophilic patients with the advanced knee arthritis frequently present with a complex knee deformities. The most common deformity is flexion contracture. It is usually associated with external rotation, posterior subluxation of the tibia, femoral lateral side of the valgus deformity. So in this, conservative management can be done like serial casting, bracing and orthosis. Walking aid should be given so to decrease the stresses on the joint, and adaptations in the home, school and work environment so that the patient participates in the community activities and his work and school. Surgical management, arthroscopy and osteotomy can be done for the angular deformities. And as discussed, prosthetic joint replacement, hip, knee can be done. Last option will be the arthrodesis. So this is the rehab of the total knee arthroplasty. Here, generally, when it is a planned procedure, so we will give prehab exercises for around 3 to 6 weeks. So prehabilitation is a strategy to enhance a patient's physical and mental well-being before the medical procedures like surgery, to improve the ability to withstand the procedure and facilitate a faster, more complete recovery. So it is a proactive approach that aims to minimize negative impact of the treatment on the patient's functional capacity and overall health. So generally, the post-surgical and the post-op rehabilitation of the TKR goes as the conservative management of what we do in TKR. The only thing is that we have to be very careful and cautious while dealing with the hemophilic arthropathy patients, because a little overstretch can again rebleed the muscles. Then coming to the pain management part. Pain management is a very crucial part in rehab. Like ice packs will vasoconstricts the blood vessels, which will lessen the swelling. Physical agent modalities, ultrasound, IFT, muscle stimulators can also be used. Kinesiotaping methods like inhibitory, facilitatory, and lymphatic are a good option. MFR is done to break soft tissue adhesions, and splintage, and protective cuffs can be given. Facilitate ADL work and leisure. In ADL, generally the patients of hemophilia generally complains difficulty in walking, squatting and stair climbing are the major concerns. Work environmental modification, use of ergonomic and biomechanical principles can be utilized. In leisure, avoid contact sports, outdoor sports, games. So traditional games like Kho-Kho, Kabaddi and 7-piece can be avoided. These are the mobility aids. As and when required, as per their tolerance of joint pressure, this can be used. Forearm crutch, the other crutches, walkers, sticks, wheelchairs can be used. These are the ADL adaptations. So as I mentioned, they have a difficulty in squatting. So the seat chairs can be modified. The toilet seat chairs can be modified along with the grab bars. Anti-slip mats can also be used, and reachers can also be used for, as they cannot squat or they cannot bend from the hip. These are the environmental modifications. So make we have to make design accessible to everyone in the society. You can see in the picture, there are staircase, but there is also a ramp. There is also a grab bar. So this can be used by many people. Ergonomic modifications at work. This includes assessment and intervention to enhance injury prevention. So newer technologies and wearable devices can also be used. Vocational counseling. As this hemophilic patients have generally they are suffering from joint pain and hemarthrosis. So it is recommended that they go for a sedentary or light job or light vocational activities. So in this, use of technology will be the best option. This has to be counseled to the family and the caregivers. Return to work in hemophilia, those people who are in a midlife or they are young adults. So of course, they want to return back to their work and occupation, as it is very advantageous. It will improve the mental health. It will faster physical recovery and function as a result of movement. Of course, it will provide very financial security. Work also provides a sense of pride, identity, and achievement. Will gain self-esteem, satisfaction, and challenges. It will also take part in social activities, relationship building, and gain support. Schooling issues in hemophilic kids. So here, of course, we have to counsel the parents as well as the teachers, principals. So some strategies like, convert the PT class into hobby or fine arts. Alternative methods of disciplining behavior modification. Generally, we have seen in the OPDs that, because of the negative reinforcements and the use of some negative reinforcement, the child has got a severe bleed in the hand and the forearm. Then academic concession can also be given, like extra time or rescheduling of the assignments and exams, etc. Joint protection techniques have to be taught to the patients so that their joint pressures are minimized, and of course it won't go into arthropathy. To stop the activity before the point of discomfort. Avoid activities that put strain on painful or stiff joints. Avoid static position for long period of time. Avoid flex joints while sleeping. Lose weight. Use stronger and larger joints for activities, and balance activity and rest. These are the splints, some static splints which can be given. So we have got posterior knee guard and the L-shaped splint for the ankle. These are the protective cuffs and the headgear. So we generally encourage the children to use the protective cuffs, because many a times they bang on some objects and they have got the elbow and knee bleed. So this will minimize the effects of the bleed. And the headgear, of course, if they are learning skills like cycling, or if they are running and if they fall, they can have a severe trauma to the head. These are the clinical case examples from the OPD which we have dealt with. So this was a case of triple knee deformity where the knee was in flexion, external rotation, and posterior subluxation. So we made a serial static correction splint. This is a type of static progressive splint for fixed flexion deformity. This was a pseudotumor seen in the right knee, but ultimately this person got knee amputation. After that, prosthesis was given to him and now he walks very well. This is a Robert Jones for the VIC of the forearm bleed. Is a correction of flexion deformity at the elbow joint using a low cost serial static splint. This is called an anterior elbow guard. This was a case where he got a lymphedema post THR. So lymphedema type of kinesiotaping was done. It minimized, of course, series of taping was done for almost 2 to 3 weeks. After that, he got a minimized lymphedema. To summarize, if there is an acute hemarthrosis, the patient will require prophylaxis and exercises. If this does not go well, this can go into chronic synovitis, where again our treatment will be prophylaxis, radiosynovectomy, splint, and exercises. Again, if does not go well, then lastly the stage occurs is the arthropathy, where joint protection measures, exercises and pain management have to be done. So why rehabilitation is simple yet difficult in hemophilia? So see, this is the patients in hemophilia. Generally, when there's a bleeding, we tell them to rest, right? So, but because of the rest, so there's a reduced activity. This will lead to reduced fitness. Reduced fitness will lead to decreased return to activity, and because of that, the muscle will again bleed. Again, the deterioration, joint surfaces, synovitis, pain. So the patient then goes into a vicious cycle of the hemarthrosis, synovitis, hemarthrosis cycle. So it seems that the simple methods of rest is not useful, but you have to deal it very carefully, and a disciplinary approach should be utilized. So exercises, if done correctly, will of course help the patient, as it will make the muscle strong, good and flexible, coordination and reflexes, which can lead to a quicker recovery time after the bleeds and fewer problems after bleeds, that can, so that the patient can continue with the normal health style. Of course, if it doesn't bleed, still the exercises will be a very good for them to protect the joints and decrease the joint bleeds, which again can lead to a normal healthy lifestyle. So take home message from this lecture is longitudinal assessments of the musculoskeletal health is required from time to time. Therapists are the health promoters. They also help in injury prevention, treatment, interventions and rehabilitation. It is essential to work in a multidisciplinary team rather than an individualized approach. Customized rehabilitative program is of course advised, because the guidelines are only there to help the patients. Proactive therapeutic interventions to encourage physical activity and prevent musculoskeletal complications. And lastly, encourage the persons with hemophilia to be active and optimize their well-being and their health outcomes. So this was a part of the centenary celebrations as well as the 75th year of the Occupational Therapy Department, but also the upcoming World Hemophilia Day is on the April 17th. So which recognizes all the bleeding disorders. Thank you very much.
Thank you, sir. It was helpful how we can use and make tailor-made programs for our patients. Also about how we can use splinters, adaptive devices, assistive devices for our patients. It was a great insight for us how we can use and prevent injuries, and if patient has a bleeding or acute injury, then how we can use various protocols like price, pulleys and everything. So the question is, could you please explain the Bloomberg sign? Saurabh sir would be answering it.
So the Bloomberg sign is for the appendicitis and like that. So it is a pain upon removal of pressure rather than application pressure on the abdomen. So whenever the physician presses the abdomen, there won't be any pain. But when the physician removes the pressure, that time it will pain. That is called a Bloomberg sign.
So next question is by Jitin Mittal, that what physiotherapy exercise should be taught to hemophilic patients after post-fracture?
So it is like, very subjective question, because it depends on which side the fracture has happened, what was the pre-fracture status of the patient. I think for that question to answer, if I think you are looks like you are on a PWH. So to answer that, to get that question clarified, first you need to go to a center where there are therapists available, get yourself assessed well, and then accordingly we can decide upon what will be the protocol to be followed. Because there could be multiple fractures, fracture at the lower limb, fracture of the upper limb. So accordingly we have to see what kind of fracture is there, and then accordingly in that specific joint the exercise can be initiated.
It will also depend on what does the orthopedician suggest. If it just requires a rest or if it requires some surgical intervention. So depending on that, the rehabilitation will follow.
Yeah. Any more questions?
Any other questions anyone have, or we'll move forward?
Regarding the.
Okay, I think we missed one question which was above. Just a second.
Varti scroll.
Okay, so the question was, how can we plan a pre-operative therapy for TKR?
Okay, so this pre-operative therapy itself means a prehabilitation of TKR, right? So knowing that the patient post TKR will be having weakness, right, restricted ranges, and so on. So in prehabilitation, this phase of prehabilitation is for around say 3 to 4 weeks, and in that we will try to activate the muscles of lower extremity, so that knowingly when it will be undergoing the TKR, it will be less. Otherwise, the management and the exercises remains the same.
Okay, thank you, sir. There is one more question. Can you please explain how to assess the trunk stabilizers in patient with severe muscle atrophy?
See, the trunk stabilizers are mostly multifidus, right, which we cannot see. Okay, so if they are going into atrophy, that we cannot see, right? We'll only understand that these muscles are getting tight because they are stabilizers. Atrophy will be seen in the muscles like mobilizers, like hamstrings, quadriceps. Here we can see the atrophy part, not in the stabilizer muscles.
What would be the significance of
the stabilizers? If they are very tight, it can lead to inhibition of the other muscles, other global mobilizer muscles. From this, we have to judge and evaluate the muscles, mobilizing muscles.
So another question is, what would be significance of Bloomberg sign?
Significance of Bloomberg sign. Okay, that don't get confused about the Bloomberg sign. That is not related to the hemophilia. Okay, when there is a iliopsoas bleed, okay, that time it mimics like having a appendicitis, right? That's why it was written that Bloomberg sign could be present in such cases, right? It is not for the hemophilia. That is just to check if it is really a appendicitis clinically or a iliopsoas. Of course, better methods are like ultrasonography and MRI scans.
Okay, thank you. So we have another question by Jitin Mittal, is that ultrasound, I think he means ultrasound can be applied if swelling and redness disappears.
On what?
So like Jitin, can you please clarify where and what, like in general you are speaking, or any specific part after injury or something like that? At knee joint, but like after
as we have explained in this whole session, that the knee joint goes into a phases of destruction. So if it is an acute bleed, or it is in a subacute, or it is already gone into a chronic synovitis, then there are stages where we have a indication for ultrasound and a contraindication for ultrasound. So like if there is an acute bleed, maybe to some extent we use it. In end stage arthropathy, we use it sometimes over the muscles, but not in a chronic synovitis. So it again, I think you are a PWH again. So after active, bleeding disappears.
After that, you won't require ultrasound. Ultrasound shouldn't be used regularly.
Here at our center, we use ultrasound only in the acute phase, that too only for 5 days. Later than we don't use any kind of an ultrasound. And we use ultrasound only as an adjunctive therapy. And mostly our therapeutic interventions are on exercises. So just to reduce the pain or swelling, ultrasound can be used. Later on, mainly you have to work on your muscles and your joint health.
So I hope that cleared your doubt, Jitin. If any other things, you can always come to our OPD for further evaluation and your intervention. So if there are no more questions, then we'll move forward with the webinar. Okay.
Questions, we can email the question.
Yeah, if you guys still have further any questions, you can always email it or reach us out on the phone numbers. We will send it on WhatsApp at any time you can.
Also, this webinar is recorded.
And for everyone who was asking for PPT, we have recorded the webinar and we will be sharing the recording link soon. So please stay tuned for that on the WhatsApp group, and we will also share it by email. So I will move forward with a vote of thanks. On behalf of the organizing committee, I feel honored to deliver the vote of thanks for today's insightful webinar on hemophilia in musculoskeletal conditions, emphasizing the significance of the role of occupational therapy. We extend our sincere gratitude to our respected Dean Madam, Dr. Sangeeta Rawat Ma'am, and Academic Dean, Dr. Harish Pathak Sir, for their steadfast support and leadership in promoting education and clinical excellence. We also give our gratitude to Superintendent Dr. Mohan Desai Sir. A special thank you to our Head of Department and Associate Professor Dr. Karuna Nadkarni Ma'am for her continuous guidance and motivation. We are deeply thankful to the Hemophilia Comprehensive Care KEM at KEM Hospital for their multidisciplinary contribution to hemophilia care and management. In particular, we would like to express our heartfelt appreciation to Dr. Chandrakala Ma'am, Head of Department Hematology, Dr. Mohanty Sir, Head of Unit Orthopedic Department, Dr. Shwetal Pawar Ma'am, Radiologist, Nuclear Medicine, and Akshita Sister from Hematology Daycare Center for their unwavering dedication, collaborative spirit, and vital role in supporting patients and this initiative. Our appreciation also goes to Hemophilia Federation of India, New Delhi, National Health Mission, Maharashtra, Hemophilia Society Mumbai chapter, and Hemophilia Society Thane chapter. So, for their active collaboration and advocacy in this field. A special mention to RRC Regional Resource Center Western Region NMCN, supported by Ministry of Health and Family Welfare, Government of India, for the technical and infrastructural support that made this webinar accessible and impactful. Heartfelt thanks to all the patients for their presentation and participation, strength and willingness to share their experiences. We would also like to warmly acknowledge Prakash Kaka, our dedicated ward boy, for his consistent behind-the-scenes support and presence. Lastly, a big thank you to all the participants. Over 400 of you have registered for the patient hearing, curiosity, and active involvement. Your engagement made this session truly meaningful and successful. Let us continue our joint efforts in raising awareness, delivering compassionate care, and support the hemophilia community. Thank you.